Attendees are in listen-only mode.
Hello and welcome everyone. We're just going to wait for everybody to start coming in. We've got about 50 people here today. Sorry for the late start. We had some technical difficulties, but we are ready to roll. All right, and then just to know as you're coming in that all microphones and cameras are going to be off. If you do have a question or comment, you are going to have an area on your panel that's going to give you the option to enter your questions there. Okay. So since we are about 5 minutes in, I'm going to go ahead and get started if that's okay with everybody. So good morning or afternoon at this point. Thanks for joining us today for our Radiation Therapy for Breast Cancer webinar. I'm Jamie Montgomery. I'm the project coordinator for Oregon Pacific Area Health Education Center. We are a hosted agency of Samaritan Lebanon Community Hospital, but today I will be your host and moderator for today's CME. So we're going to go over just a few housekeeping items here for everyone. On your GoToWebinar control panel, you'll notice, like I said, that all microphones are muted. They're going to remain muted during this session. If you're experiencing audio difficulties, please make sure your computer speaker volume is turned up or use your phone option to listen in. There is going to be a section specifically for handouts. This is going to be the slide decks that are going to be provided to your CME today. You can download those and they are in the handout section for you to do so. If you do not see that or you have trouble downloading the slides, please email me and I will make sure that I get them to you within the next 24 to 48 hours. So for today, you're going to be using this activity code on eads.com. The activity code for today's CME is 88DINE. To obtain CME or CE credit for this activity, you must log into the eads.com website, enter this activity code. So please make sure you do write the activity code down for your records, and please email me if you have any trouble at all getting this activity code entered on the website. So the presenters and planners of this activity have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used on or by patients. And today's presenters are going to be Dr. Carrie Cook with OHSU, as well as we will have a guest speaker at the end who is going to join us, Dr. Jessica Dramino from Samaritan Oncology Department and Radiology. And so with that being said, I am going to go ahead and let Dr. Cook introduce herself as well as get her slideshows going. One moment, please.
Hi, everyone. I'm Carrie Cook. Thanks so much for having me. I'm working on the... Okay, does it look okay on the screen?
It looks perfect.
Okay, wonderful, thank you. Yes, so hi, I'm Carrie Cook. I'm a radiation oncologist at OHSU. I'm an assistant professor. And today I'll be talking to you all about radiation therapy for breast cancer. I tried to keep it really basic. It sounded like, you know, this was just an opportunity to kind of go through some of the basics about radiation for breast cancer. So I'll be going through some general principles about radiation. But then I'll touch on each of sort of the main categories of breast cancer, you know, pre-invasive breast cancer, early stage, late stage metastatic disease. And then I'll do a little bit about sort of the logistics, side effects, and planning of radiation, just so from a practical standpoint, you guys get a sense of what's going on with there. And I tried to bring in some of the more recent data as appropriate without getting too into the weeds. So getting right into it, you know, why do we do radiation? So basically, after surgery, I think that we can all agree that there's some risk of residual microscopic disease left in the breast after surgery. Depending on certain disease characteristics, that risk may be higher locally or systemically. Systemic therapy is effective, but it may not penetrate fully into areas of disease depending on where there's vasculature or aberrant vasculature from tumors, or if there are larger clumps of cells that it can't penetrate into. But nothing is going to stop radiation traveling through tissue, and so the way I describe it to patients in terms of why we do radiation is we're basically blanketing the highest risk areas in radiation to take care of any microscopic disease that may be left. But because breast cancer represents such a heterogeneous group of patients, and each one we're taking into account those patients' individual risk factors, like what is their personal risk of local recurrence, what would happen if they did recur locally, will radiation impact their survival, and what are we losing by radiating them? So, you know, what are the risks of side effects, and how do we find the balance there? So starting with DCIS, something that we know isn't going to be impacting patient survival. There are waves of news articles, et cetera, about DCIS and, you know, what should be done, whether these patients should even have surgery, are we over-treating them? But one thing we know for sure is that for patients who have surgery, when you take all comers with DCIS, radiation reduces the risk of local recurrence by about 50%. And that's regardless of, you know, patient age, use of tamoxifen, grade of DCIS, et cetera. And when DCIS recurs, it recurs about half the time as DCIS again, and about half the time as invasive disease. And so that may mean different things. So if someone has a 30% chance risk of recurrence and we brought it down to 15%, you know, then maybe we should consider doing it. But if someone's baseline risk of recurrence is 4% and we bring it down to 2%, then it's more of a discussion about whether we should even consider treating them. The most recent data we have for sort of average risk or low risk DCIS patients were the 15-year results of RTOG 9804, which were published last year. You can see that there's small numbers overall with recurrence, but even for low risk patients, radiation significantly reduced the risk of recurrence. And we know from this and other studies that the risk of recurrence tends to follow this sort of 1% per year without plateau recurrence risk without radiation. And so I often use that number for patients, you know, saying, well, do you expect to live 20 more years? Because then, you know, ultimately there's probably a 20% cumulative chance of recurrence. There are other tools, you know, I usually start with these numbers, but there are ways to better personalize a patient's risk. For example, you can use the Memorial Sloan Kettering DCIS nomogram, where you put in information about each patient's particular disease characteristics and get numbers for the risk of recurrence with or without radiation and with or without endocrine therapy. Those can be great for patient discussions as well. Alternatively, more recently, there's a genomic test that exists called DecisionRT, which I found quite useful as well. It's a send-out lab where, you know, it looks for genetic mutations within the tumor tissue and basically spits out a number from 0 to 10, with anything from 3 or less being low risk and higher than 3 being elevated risk. So I like to use this in patients who maybe have intermediate grade DCIS, you know, maybe they're in their 50s or 60s, they're not sure about whether they want to have radiation or not. And so sometimes I get these back and it looks like this, where it's like, oh, 30% risk of recurrence without radiation and 9% with. But sometimes I get them back and it's a 7% without radiation and 7% with radiation. And so that provides a level of comfort and justification to omit radiation in those patients. So moving on to early stage breast cancer. So now we're talking about invasive disease, but early stage. I mentioned that earlier about residual microscopic disease in patients after surgery. We know that after a lumpectomy, the residual breast tissue is at risk of harboring microscopic disease. We know this from the classic NSABP trial that compared mastectomy to lumpectomy alone to lumpectomy plus radiation, found that mastectomy and lumpectomy plus radiation are equivalent, but that lumpectomy alone had elevated local recurrence rates, as you can see by this graph from that study. So lumpectomy plus radiation became a standard of care for women who did want to preserve their breasts and had early stage breast cancer. It's true that a majority of women will choose breast conservation, but it's important to counsel them that mastectomy is a perfectly reasonable option, whether it's because they can't receive radiation because of some other condition, or they're very averse to radiation for some reason. But I always counsel them that if they choose to do a mastectomy, it's likely that they won't need radiation, but you still need the final pathology just to make sure there's no features that would necessitate post-mastectomy radiation. So for talking about the impact on survival, contrary to DCIS, when you talk about treating patients for early stage breast cancer, there is actually a survival benefit to doing radiation. It does impact breast cancer mortality. And the way that the authors say that, translates well to patients is that every 4 local recurrences prevented, there's 1 breast cancer death avoided. So for these patients, at least in a certain age group, we recommend radiation for all patients after lumpectomy. But we're talking about a heterogeneous group of patients. So there's obviously a spectrum of how much benefit will be derived from radiation. If you look at the NCCN guidelines, it says, negative axillary nodes, you give radiation, or you can consider APBI. But there's definitely more nuance to this. So we do tend to discuss omitting radiation with very low risk patients. And so specifically that's based on these 2 trials, the CALGB trial and PRIME2, both of which were asking the question of, do we need to do radiation after a lumpectomy for low risk patients? So both of them were very similar. PRIME2 was in 65 and over. CALGB was in 70 and over. These were estrogen positive, small tumors, no really high risk features. I believe they both allowed for grade 3 or LVSI, but not both. And they had nearly identical results, basically showing that the recurrence rate was 10% at 10 years without radiation and 2% at 10 years with radiation. So we can see that same sort of 1% per year risk of recurrence. But in this group of patients, there was no impact on the overall survival. So with these patients, I tend to, look at their overall performance status. I give them these numbers and see how they're feeling about it. What is the, how do they feel about a local recurrence and what that would mean? It would mean additional surgery and workup and things like that. I also talk to patients about their willingness to do endocrine therapy. Most but not all of the patients on these trials had endocrine therapy, and so if they tell me like, no way, I'm not even going to consider endocrine therapy, then I say, well, maybe you should consider doing the radiation. This question is being asked in a younger group of patients. So the DEBRA trial is basically the same design, randomizing women after their lumpectomy to endocrine therapy alone versus endocrine therapy and radiation. But this is in the group of patients aged 50 to 70. Same thing, small size, ER positive, HER2 negative. They have this added criteria of an oncotype less than 18, just to make sure they're truly low risk. We do have this open at OHSU, and so it'll be interesting to see whether in the future this is a group of patients that we can give the option of whether or not to have radiation. In terms of how we treat early stage breast cancer, we've known for quite a while now that hypofractionation, or 3 to 4 weeks of treatment, is equivalent to standard fractionation, or 5 to 6 weeks of treatment. And this is appropriate for pretty much any patient in whom we're not covering the regional nodes. So this is longstanding data. And in fact, many insurance companies won't even approve standard fractionation in this patient group anymore. However, there's some newer fractionation schemes to discuss where we can treat in as few as 5 treatments. So the first study that came out looking at this was back in 2011, and it was women aged 50 with node negative early, or 50 and over with node negative early stage breast cancer. Since it was an older trial, the standard arm was the standard fractionation, or 5 to 6 weeks of treatment. And then there were 2 different radiation dose levels being given in 5 treatments total once weekly. And this was sort of just proof of concept. So the primary endpoint of this study was actually just a cosmetic one. It was a 2-year change in photographic breast appearance. But it wasn't designed to look at, recurrence rates or survivals or things like that. However, you can see here that this is the percent of patients with, no, moderate, or marked breast shrinkage. And these 2 lines are the standard arm and the 28.5 and 5, and those are equivalent in terms of cosmetic outcomes. The 30 and 5 was a little bit worse, and so they dropped that arm. And then they moved forward with the next phase of that, which was the UK Fast Forward trial, which instead of giving once weekly, they lowered the dose slightly and looked at giving it in 5 treatments just in 1 week, so daily, Monday through Friday. They also expanded the eligibility criteria, so this was women 18 or over. They even had some node positive patients or patients with larger tumors. But I will say that the majority of patients on this trial were sort of still that low risk group. So the median age was like late 50s, and it was mostly ER positive, lower risk patients. And they published their results with 5 years of follow-up. One word on the side effects, just briefly, is this is a little bit of a busy graph, but you can see in the like medium gray is the hypofractionated arm, or the 3 weeks of treatment. And you can think of this as sort of the duration of side effects. So this is grade 1 and grade 2 toxicity. So you can see that the amount of time that people spend with side effects is quite a bit longer with the hypofractionation versus the 1 week or ultra hypofractionation. And the side effects do tend to be a little bit milder in the shorter course. So I usually tell patients about that too. And then, like I said, published at 5 years of follow-up, and you can notice the y-axis here, it only goes up to 3%. So we're talking about really low risks of recurrence. And basically these were non-inferior. So these were equivalent in terms of outcomes. The 27 gray was a little bit worse in terms of cosmesis, so they stuck with the 26 gray. But we have now 1 study, 5 years of data showing that this is equivalent in terms of outcomes. So I do bring this up to patients quite a bit, especially those who are lower risk, and I give them the caveat that, in normal times, we would probably not be changing our practice based on something that only has 5 years of follow-up. We tend to be more conservative than that. But this study came out in April of 2020 at a time where I'm sure you all remember we were sort of freaking out, trying to figure out how to treat people more quickly. We didn't know what to do. And so a lot of us became earlier adopters of this regimen. I don't expect the results to be different at 5 or at 10 years. If they are drastically different, I would be very surprised. But I still try and counsel patients, you have to have some comfort level with the fact that this is not technically a standard of care yet. But that said, it's been a great option for, again, these low risk patients or people who have travel issues, they live far away, you know, work restrictions, these types of things. So I've used it quite a bit, and it's been going pretty well. Another option for our low-risk patients is partial breast radiation. So, you know, historically, standardly, radiation's been given to all the residual breast tissue. But with the assumption that the highest risk area would be the area around the lumpectomy cavity, there's been more interest in APBI, or accelerated partial breast radiation. So there's a number of different techniques that you can do to give APBI. We usually, well, exclusively use external beam radiation here at OHSU, but there are ways to give it with brachytherapy or implanted radiation as well. This is a busy slide, and you don't really need to know this, but just to say that ASTRA, our national organization, puts out guidelines for which patients are appropriate to have APBI. So, you know, certain things make people at too high of a risk where, you know, we wouldn't want them to have partial breast. I usually tell patients that in addition to meeting disease criteria, they also need to meet some anatomic criteria as well. So for example, if the lumpectomy cavity is too large relative to the breast size, or if it's too close to skin, you know, the whole thing is pressed against the skin, then sometimes I'll default back to whole breast radiation just to avoid some of those cosmetic issues or extra scar tissue. The most recent data we have for APBI is this trial out of Italy that came out in 2020. This was also randomized patients to the standard fractionation to a 5-treatment APBI course. So previously we were doing 10 total treatments given twice daily for APBI. Now we have an option that's just 5 treatments given every other day. And these were found to be not significantly different, 10 years of data. So, and this was also done with an IMRT technique rather than 3D conformal. And so in this trial, you know, cosmetic results had been mixed in some of the older APBI trials, but in this trial, APBI actually had better acute and late toxicity and both physician-reported and patient-reported cosmetic outcomes. So this is the preferred regimen per NCCN now. It's what we've been using here. I don't know if the IMRT technique may be contributing to some of these improved toxicity, just maybe a little more skin sparing, but I've had really good results with this type of regimen too, and I feel comfortable with it because, you know, we've got 10 years of follow-up on it. So I use this one quite a bit as well. So moving on to locally advanced breast cancer. Post lumpectomy, we know that all these patients are going to at least need radiation to the whole breast. And so the question becomes the inclusion of the regional lymph nodes. You know, how much, if at all, should we be treating those? Post mastectomy, we have to consider the same thing. Are there additional lymph nodes at risk? Is the chest wall at risk? What complications do we need to worry about with the type of reconstruction, et cetera? And after neoadjuvant chemotherapy, things become even more complicated. And I will say that probably each of those topics could have its own hour lecture, so I'll try and do what I can with it. So what does NCCN tell us? They say that we should definitely be doing radiation to the lymph nodes in patients with 4 or more positive nodes. And we should probably be doing it in patients with 1 to 3 positive nodes. But this is considered to be a little bit controversial. So why is there controversy in the 1 to 3 nodes positive population? And without getting too into the weeds on data, I'll tell you briefly what we have. So post-lumpectomy, the 2 main trials we have here are MA20 and ERTC, in which patients were randomized to receive whole breast radiation with or without inclusion of the regional nodes. MA20 was all post-lumpectomy patients. ERTC was about 75% post-lumpectomy patients. And most of these were 1 to 3 node positive patients. EORTC trial actually also included high-risk node-negative patients, which you think would skew the data away from benefit, but they consider high-risk node-negative as like upper inner quadrant, these types of things. Both of these trials demonstrated a significant, though small, benefit in disease-free survival, and the toxicity was relatively mild, low rates of pneumonitis, low rates of lymphedema, and keep in mind that most patients had at least a partial axillary dissection in this trial. Post-mastectomy, the Danish and British Columbia sort of landmark trials of post-mastectomy radiation. These included patients with any number of positive nodes and were treated with regional nodal radiation. And these trials showed not only a local regional recurrence and disease-free survival benefit, but also an overall survival benefit, even though it was small. So, and additionally, the Danish breast cancer group did this elegant study looking specifically at including the internal mammary nodes. And what they did is, since including internal mammary nodes is a little bit harder on the left side because we have the heart dose to deal with, they just randomized, well, didn't randomize, but they treated all of the right-sided patients with internal mammary node radiation and left-sided patients without. And just with that difference, with inclusion of the internal mammary nodes, they actually were able to demonstrate an overall survival benefit. And this was presented at ESTRO last year, I think, with 14 years of follow-up. The overall survival benefit is still there. The effect was more pronounced in those at a higher risk of positive internal mammary nodes. So those would be like medially or centrally located, or patients with more significant axillary nodal burden. And just one word on lymphedema. So this is one of the side effects that we're thinking about and trying to avoid when we treat patients' lymph nodes. This is a great study, if you haven't seen it yet, just to be able to quote some of those numbers to patients. So I usually tell patients that, the bulk of the risk does come from the surgery. And so you can see here the rates of lymphedema in sentinel node biopsy alone. And then when you add regional nodal radiation to that, so it's 8%, radiation adds a few percent to that. With an axe dissection, it's about 25%, and then when you add radiation, it adds an additional 30% to the risk. This is a relatively conservative definition of lymphedema, so this isn't, I tell patients this is just the risk of any basically increase in arm volume at 3 months. I don't think we're seeing really bad lymphedema the way that we did a couple of decades ago, but it's just a good way to talk to patients about, the risks and benefits of including the regional nodes. So back to the controversy. So why is it controversial? If the toxicity is relatively mild and we have randomized data with a significant benefit of including the lymph nodes, why are we talking about it? And the reason is there's been a number of retrospective studies that suggest that failure rates are pretty low in this patient group. So like around 5%. And so, maybe the benefit from those trials is really only being driven by a particular group of high-risk patients. And so one thing that's been useful from some of these studies is that they've been able to identify some of the factors that we know predict for recurrence in this patient population. So everyone that I see with a low node positive, low burden of nodal disease, I sort of individually think about all these factors. Are they young? Is it high grade? Is it ER negative or triple negative? Do they have LVSI? Did they have 2 to 3 nodes involved versus just 1? Did they have higher nodes that were positive? ECE is a predictor, or extracapsular extension is a predictor for supraclavicular failure. And how many lymph nodes were removed. The other things would be like multifocal disease, just all your average high-risk features. And so if somebody has a lot of those, even if they only have one lymph node involved, then I do tend to lean more towards covering all of the lymph nodes in that patient. I didn't put a slide in for this, but I'm just recalling now too that we have a study open here as well for the low nodal burden node positive patients, which is called Taylor RT or MA39. It's a kind of similar in that it has to be patients with a low risk oncotype, and they need I think fewer than 3 nodes involved, and it's randomizing patients for inclusion of the lymph nodes or not. So if they're post-lumpectomy, they're randomized to whole breast radiation versus whole breast plus the lymph nodes. If they're post-mastectomy, then they randomize to post-mastectomy radiation versus nothing. So that's something that you can consider opening and enrolling patients on, since it is kind of a controversial group. One of the most challenging areas for us as radiation oncologists is in the post-neoadjuvant, post-mastectomy group. So we know from the early post-mastectomy radiation trials that I mentioned that radiation improved all of those outcomes in women with any number of positive nodes. However, in those trials, systemic therapy was given after surgery. It was also sort of a now very outdated type of systemic therapy. And so what we don't know is how much the better systemic therapy is impacting the benefit that we can give with radiation, and B, how the response to systemic therapy might predict someone's expected benefit from radiation. And so particularly in this group of patients who have clinically node positive disease and then have a complete response in the lymph nodes. So thus far, we've been guided mostly by either retrospective data or extrapolating from prospective data that doesn't exactly apply. The most robust retrospective data is this MD Anderson study, came out in 2012, looking at patients who had neoadjuvant chemo and sort of which groups or which factors predicted for benefit. So this showed a benefit to PMRT in patients with clinical T3 or higher disease, clinically N2 or higher disease, and young patients age less than 35 with either clinical stage 2 or 3 disease, regardless of a pathologic complete response rate. However, the recurrence rates were low in patients with clinical T1 to 2 and 1 disease and a pathologic complete response in the nodes. I think that radiation oncologists are split on this issue and how to manage these. Many people do consider omitting in this patient group, but others are more hesitant to base decisions like that on retrospective data. Fortunately, we have a hot off the press prospective trial that was looking at this question. It's not a randomized study, but it was a prospective registry study looking specifically at this difficult group of patients. So they just had to fit into this group and have at least 3 cycles of chemo. And this is a busy table, but I just wanted to point out that they stratified patients into risk groups. And so it has to do basically with the clinical stage, the pathologic stage, and what type of axillary surgery they had. They do have these qualifiers for if people got sentinel node biopsy before chemo, which we don't really do here in the States, at least not at OHSU, but otherwise we, kind of applies to our patient population. So low risk was basically a path CR in the lymph nodes, regardless of the type of axillary surgery. And they just got regular whole breast radiation if they had a lumpectomy, and then nothing if they had a mastectomy. In the intermediate risk group, this was basically YPN1 with an axe dissection or YPN1 mic if they had a sentinel lymph node biopsy. And they did sort of this de-escalated radiation where they included just the low axilla rather than the comprehensive regional nodes. And then the high-risk group was everyone else, and they got regular radiation to everything. Again, busy slide, but I wanted to point out some things about the patient characteristics, namely that the majority of patients got an axillary dissection, around 80%, and also about 25 to 30% of patients got more radiation than what the study recommended. And here are the results, and again, not randomized, but this is just showing the local regional recurrence, recurrence-free survival, and overall survival. The red is the high-risk group, blue is low risk, and green is intermediate risk. And you can see basically that the recurrence rates are really low. The overall survival rate was worse in the high-risk group of patients, but overall, pretty good. 92%, 87% in the low and intermediate risk groups. And this is with de-escalated radiation. So still no randomized data in this space. We're all eagerly awaiting the results of NSABP B51, which is a randomized trial that is looking at exactly this question. But this trial does make me a little more comfortable considering scaling back radiation in this group of patients. So for example, I had a patient recently who was in her 70s and had HER2 positive disease, had a pathologic complete response. And so because of this trial, I talked to her about it and we felt comfortable scaling back, where in the past, I think I would have leaned towards covering her comprehensively. So just a couple words on palliation or metastatic breast cancer. It's of course more the area of the medical oncologists in the audience, but I just wanted to briefly point out some of the ways that radiation is used. We treat chest wall masses. This was a patient I treated a year or two ago, and you can see how effective it is at relieving these issues, drainage, wounds. We can palliate pain all over the body as well. Oligometastatic disease is an area of interest across all disease sites, but unfortunately the results have been a little bit disappointing in the breast cancer space. NRG-BR002 was a breast-specific study looking at oligometastatic patients with controlled primary disease, randomizing them to standard of care systemic therapy plus or minus metastasis-directed therapy. No difference in results, and so the trial will not continue to a phase 3 portion, unfortunately. There was another study that included breast and lung patients with oligoprogressive disease, so up to 5 lesions progressing, and they get SBRT or stereotactic radiation to the sites of progression versus standard of care. There was an improvement in this trial, but it was driven entirely by the non-small cell lung cancer arm, which is unfortunate. People look at this and they say, well, a lot of patients were triple negative. Maybe we're not selecting the right patients for these trials, but so I think it's still worth looking into, maybe with a little stricter inclusion criteria, but not super encouraging results so far in that space. So now I'll just run through a few slides about the practical things. I find that a lot of people don't, it's a little bit of a black box what we're doing. I know there's some radiation oncologists in the audience too, probably, so sorry if this is boring for you, but sort of what happens once they come to us. We do a radiation planning scan. People do this differently. I tend to contour the breast tissue and then use that to decide how I'm going to place my radiation fields. There's a number of different techniques, some of which we discussed earlier, but people use different radiation techniques to cover the whole breast tissue, partial breast tissue. We use deep inspiratory breath hold here to avoid the heart. You can see this is the same patient, same slice, because she has this little clip here, and you can just see the difference of where the heart is in space when she's holding her breath versus free breathing. And so when we're coming in sort of at an angle here. It's a lot easier to avoid the heart when the patient has her breath held. Another one of the challenges that we face are patients with pendulous breasts. You know, if they have skin on skin, there can be hotter side effects or more dose in that area. So we use a prone board to treat those patients where we have them kind of laying on the table like this. That allows for skin separation. It's also a great way to avoid the heart in a patient who can't tolerate the breath hold technique. Just briefly, I mentioned that you can use brachytherapy for partial breast as well, but here we do favor external beam. Once we've decided on a technique, we generate a treatment plan. We use this to calculate the dose to the breast and any organs at risk. When we're covering the lymph nodes, we may wind up coming onto the other side a little bit to make sure we're including the IM nodes. Again, weighted against the dose to the organs at risk, making sure that we're balancing the toxicity with what we're trying to do. Some other anatomic challenges that we face, some patients really just can't do the breath hold, and sometimes we wind up doing an IMRT technique to shape the dose around the heart when a 3D plan would just kind of go right through the heart. Sometimes I use breath hold on right-sided patients as well if they have small lungs and I'm not really able to meet the lung constraints. And then I have here just some images of typical side effects with treatment. So these are patients on their last day of treatment and then 2 weeks after treatment. You can see, they usually get red, a little bit rashy in the treatment field. It usually resolves pretty quickly. Patients who have some pigment to the skin tend to hold on to that pigment for longer, so they may have some longer term tanning. And then we can get this sort of dry desquamation or a little bit of peeling, especially in the underarm during treatment. Rashiness in this area or itchiness is not uncommon, but it does usually go away again pretty quickly after treatment. Again, just this is 2 different patients, but this is now 6 months post-treatment, and still they both have this slight tan. It can continue to fade, but I do counsel patients that it may remain permanently a little bit darker on that side. The other thing we counsel patients about is symmetry. It's usually subtle, but you can notice here the left side is a little bit smaller, sitting up a little bit higher on the chest wall. Here the right breast was treated and you can just see it's subtly higher. Some people you don't notice this at all. Some people it's a little more dramatic, but usually there's a little bit of a subtle decrease in size of the treated side. Patients can get texture change of the breast tissue and of the skin, and so sometimes that's enough to become visible, where it kind of looks like this peau d'orange type of appearance, but it really is just sort of scarring in the skin itself. Telangiectasias, these are just sort of like spider veins in the skin surface, more common post-mastectomy, especially if we have to give a boost to the skin. These can be, lasered if they're cosmetically unappealing. They're not harmful, but it's something that can happen. And then post-mastectomy is the risk of capsular contracture. So, where a patient's implant or expander can sort of contract up higher on their chest wall. Sometimes that can be painful or require additional surgeries. Here we radiate with expanders in, and that gives an opportunity for the plastic surgeon to, release some of that scar tissue as needed at the time of implant exchange down the line. But yeah, that's all I had. Hopefully on time.
All right, wonderful. Thank you so much, Dr. Cook. We really appreciate you being here and for that amazing presentation today. I am actually going to go ahead and we are going to have a guest speaker of Dr. Jessica Germino that I am actually going to go ahead and provide the microphone to as the presenter here, and it should be just a second.
Can you hear me okay?
There we go. We can hear you now. Perfect.
Okay. Hi there. Many of you, I think, are Samaritan radiology technologists who already know me, but for those who don't, I'm Jessica Germino. I'm the Director for Breast Imaging at Samaritan Health Services, so a radiologist with fellowship training in breast imaging. And I was asked to talk to you all about our breast imaging services here in the Samaritan system. And for those who don't know our system, we have 5 separate hospitals across the mid Willamette Valley from the coast over east toward the Cascades. So I'm just going to talk to you about what we have in our healthcare system, and at the end I'll take any questions if you have them. So accessibility to breast imaging resources is a very important public health resource, really, as mammography is the foundation for breast cancer screening and really the only studied method for breast cancer screening that's shown to reduce mortality. We also use breast ultrasound quite a bit alongside mammography, and MRI has very specific indications that I'll review. MRI is one of my areas of special interest personally, and I'll talk to you a little bit about that. And along with all of these imaging modalities, it's important that we are able to sample suspicious findings to identify breast cancers and other abnormalities in a minimally invasive way. And so we have access through all of these different modalities to percutaneous biopsy in our system. Our technologists in mammography, of course, know this very well, but 3D mammography, as our patients often refer to this, is tomosynthesis using x-rays to create 3D imaging of the breast compared to our conventional 2D or flat imaging. And what this has been shown is to basically decrease the number of false positives, so callbacks that don't result in a positive cancer diagnosis, and increase our detection of cancer. Studies have also shown that the tomosynthesis is particularly useful in women with dense breast tissue. And so in our system, we have multiple sites for mammography, ranging from Albany and Corvallis, which each have 2 dedicated mammography units in addition to stereotactic biopsy capabilities. And then Lebanon, Newport, and Lincoln City each have 1 mammography machine. In 2017, Samaritan across the system implemented 3D mammography, which was really a wonderful thing, and did not implement it piecemeal, but rather all at once, which ensured equal access to this resource across our system, regardless of geographic location. Our sonographers present, of course, know all of this about breast ultrasound. We have fantastic mammography techs and sonographers in our system. Ultrasound, not using x-rays, of course, to give us additional assessment of breast tissue. And it's a major modality that we use, and it's preferred, if possible, to biopsy lesions under ultrasound guidance. It allows use of a smaller needle, less trauma to the breast, and than with mammography or MRI. Access to ultrasound is similar to mammograms throughout our system. All sites have ultrasound machines. We have been trying to create uniform access to breast ultrasound technology, and all sites have been in the process of updating to more current models of GE ultrasound in particular. And so we can proudly offer biopsies and ultrasound assessment of the breast at any of our Samaritan sites. Breast MRI. So MRI, I don't know that I have any MRI technologists here. If you're present, welcome. But this is, again, another means of assessing the breast tissue without utilization of x-rays. And we give intravenous contrast to allow a sort of we call it kinetic assessment, but a dynamic assessment of how blood flows through the breast tissue over time to determine how suspicious something is or isn't in our assessment. The American Cancer Society and other societies have recommendations for who is really recommended for screening with breast MRI. Problem-solving use of MRI is also another indication that I'll discuss, but essentially high-risk screening should be offered to those with a lifetime risk of breast cancer greater than 20 to 25%, which can be calculated in a number of ways. Most commonly, we use the Tyrer-Cuzick risk assessment tool, and that one's really the most relevant to determination of risk and benefit of MRI. New breast cancer diagnosis patients, sometimes we will recommend breast MRI if we think it will help to define the extent of their breast cancer and screen the other breast. It's sort of a case-by-case basis. Lots of studies on this, but there is not great consensus on when, in my opinion, to use it or not amongst different fields of medicine, ranging from radiology to surgery. And so it's usually an individual case or discussed as to whether or not this somewhat limited resource should be used in a new breast cancer diagnosis case. Those who are having neoadjuvant chemotherapy, who had a breast cancer assessed with MRI before neoadjuvant chemotherapy, this can be a great tool to assess how they're responding to their therapy. We use it for problem solving as well. One of the most common that we'll see with our mammo and ultrasound techs is your assessment of bloody nipple discharge. So if we don't find a reasonable explanation on mammography or ultrasound, we will typically recommend for suspicious nipple discharge, which could be bloody or clear, that the patient undergo MRI and have a consultation with breast surgery. Rarely, but many of you have seen these cases. We have a patient who presents to us with metastatic cancer cancer in one of her axillary lymph nodes or metastatic breast cancer. And so if mammogram and ultrasound do not identify where the breast cancer is, we will go to MRI to look for a hidden or occult breast cancer. And then we can use MRI to best assess the integrity of silicone breast implants to determine if there is evidence of rupture. In our system, we have multiple magnets, but 2 of them are set up to perform breast MRI as well as MRI guided biopsies, and these are both in Corvallis. We have a newer 1.5 magnet in the Good Samaritan Hospital. This has a larger bore, so that can be ideal for patients who feel that a larger bore would help their body comfort or claustrophobia. And then this is also our go-to machine when we have conditional devices in MRI, such as pacemakers, where we will have, typically we want to do those cases on the 1.5 MRI, and we'll also have a representative from the pacemaker device company present for those procedures. 3T imaging, we have a GE in the Neville building, and most of our breast MRI is done there. It is a smaller bore, but gives very nice images and has the added benefit that the breast radiologists are right next to the MRI scanner, so we're present to problem solve if the technologists come across any questions during the examination so we can problem solve with them. So that access is nice to have the breast radiologist right there to ensure high quality imaging and Corvallis with our MRI. And then finally, I just wanted to tell you, in addition to the access I discussed above for all of the modalities for breast cancer screening and detection, we have a number of radiologists who are trained in mammography. The fellowship trained breast radiologists, in addition to myself, are Dr. Arpin, Dr. Beer, and Dr. Seberg, and we are the only ones who will interpret breast MRI. That's really such a specialized examination. We limit it to the radiologists who have specialist training through fellowship training in breast imaging. For anything related to breast MRI, including ultrasound follow-up of abnormal breast MRI, we want to limit it to our fellowship trained radiologists. Our other radiologists you can see listed on the right hand of the screen focus on mammography and ultrasound, and are also perform multiple procedures, all very talented doctors as well. And so we have a good team that collaborates with our fantastic technologists. Many of you are here, and I think you're probably one of the greatest strengths of our program as far as it goes. We wouldn't really have the high caliber imaging and ability to serve our community without excellent technologists. So thanks to all of you for showing up for this talk and for listening to me today. That's all that I have prepared for you, just a brief discussion of our resources, and I can take any questions if you have them. I'm happy to.
All right, wonderful. Thank you so much again, Dr. Jermina, for being here. I know that you are very busy today, so to take the time out of your busy schedule to be here with us was absolutely fantastic, and we really appreciate that. So right now, what we're going to do is, if you have any questions on the question menu, if you can please type your questions in, and we're going to go over some reminders. It looks like there are 2 questions currently being asked, and I have assigned those. It looks like they're both currently to Dr. Cook. And that is something that I believe we should be able to see. Dr. Cook, are you able to see those questions, or would you like me to read them?
Oh, I see one. I see, have you seen mastectomy with implant placement and radiation treatment, skin breakdown, non-healing wounds from decreased blood supply? And if so, what was your recommendation? Remove implant. So, I mean, I don't think I've seen this particular situation. I mean, often patients may have, you know, these types of things in the short term, skin breakdown and things like that during radiation. I think it would be a little uncommon to see it long term, but it sounds like, unfortunately, maybe you saw that. I think that the answer for that is, it depends. So in general, for, you know, non-healing wounds like radiation injury, there are strategies you can take, like hyperbaric oxygen is used sometimes in those situations, or the drug combination or the drug combination of pentoxyphylline and vitamin E. I would imagine that if the situation you're describing were happening, that the plastic surgeon would want to remove the implant, because I assume that, you know, the risk of infection would be there. And I think that from a healing standpoint, it does make more sense to remove it if you are in that position. And then if that by itself didn't resolve the situation, then you could try those other things that I mentioned. And that's the only question that I can see. So maybe if there's another one, you can read it.
There's another question here that says, how does radiation affect the muscles in the area long term?
Yeah, good question. So I do talk to patients about this. You know, radiation causes a little bit of scarring and fibrosis, and the amount that it does It varies by person. And so some people just go through and then they leave radiation and they have full function and range of motion and just go back to what they were doing. Some people wind up experiencing a little bit of tightness or tenderness, usually in the pec muscle, like in the upper outer part of the chest wall. Over time, that doesn't cause, it doesn't usually linger and continue to cause issues. So if people are having tightness, we usually send them pretty early to physical therapy, which helps to kind of break down that scar tissue, rebuild strength and things like that. So, you know, patients can still do, you know, work out, use their PEC, do everything that they normally do. But it's not uncommon for people to tell me they have a little bit of tightness kind of when they go way back with their arm on that side, that they feel it in the pec muscle a little bit. But in generally speaking, most muscles are pretty tolerant to radiation. So severe issues with that would be uncommon.
Awesome. Thank you so much, Dr. Cook. So that looks like that actually wraps up the questions that have been asked. So as of right now, over some reminders, again, please fill out the survey. We're going to have one more speaker before we log out. We will email you the slides by request. The recording will be available in the next 24 hours on the opahec.org/webinars-1 website. If you do have any questions or you have any requests, please email myself at jmontgomery@samhealth.org. And again, also make sure to obtain your CME logging into the credit at eads.com and enter your activity code of 88DINE. Okay, and then obviously feel free to reach out for any assistance should you need it. And now we're going to hear from an esteemed colleague, Stephanie Haggerty, who is one of the most amazing women that I have ever met, who is Samaritan's Cancer Resource Center ambassador. And I just want to make sure that we're giving her some time to say hello to everyone and to introduce herself and have a little bit of a chat with us. So I am going to go ahead and mute and let her take it away.
Hello, everybody. Thank you, Jamie. Thank you, Dr. Germino. Thank you, Dr. Cook, and thank you all attending the webinar today. The Cancer Resource Centers provide support to all of our cancer patients who are going through cancer or are survivors of cancer. And please know to reach out to the Cancer Resource Center in Albany or Corvallis. We also do have small presence in Lebanon and can easily get to the coast to be available for you if you have patients or know people who need the resources of the Resource Center. Please don't hesitate to reach out. Thank you very much again.
All right, and on the screen here for everyone, this is also another handout that has been downloaded should you want that. It's in the handout section on your control panel. Upon request, I can also send this information for amazing resources that was provided to us by Ann Webb. And if you would like that, I'd be more than happy to get that over to you. And moving on, again, we want to thank you for joining us today. Please remember to answer the survey, and thank you so much to our speakers for sharing their time and knowledge with us. Thank you so much for participating today, and we really appreciate you taking your time to join us for the webinar. We hope you have a great day today. You have now completed the webinar, and you may disconnect.